Hello everyone, good evening and welcome to yet another episode of ICPA Clinical Series, where we run each episode by the philosophy of each episode one clinical challenge. And today is the 14th episode, and I take great pleasure in having our today's speaker, Dr. Nisha Deshpande, who is an aesthetic and restorative dentist. Dr. Nisha Deshpande is a graduate of Government Dental College and Hospital, Mumbai, who went on to receive her postgraduate certificate at University of New York at Buffalo in 2011. Recently, Dr. Nisha completed her international certification in Advanced Aesthetic and Restorative Dentistry program from Igas Moniz University, Caprica, Portugal. This happened in 2021. Apart from maintaining a successful private practice focused on aesthetic and restorative dentistry in Thane for over 15 years, Dr. Nisha is also the assistant editor of Aesthetic Dentistry in Dental Tribune South Asia. Today, she'll be talking on unraveling anterior composites, and she'll be providing simple solutions to common challenges that restorative dentists face every day. And today, she'll be covering three main areas: decoding diastema closures, invisible proximal restorations, and simplifying class 4 restorations. Thank you, Nisha. Thank you for accepting the invitation, and the show is all yours.
Thank you so much, sir. And thank you for such a lovely introduction. A very good evening to everyone who's tuned in to hear this lecture live today. First off, to start off, I would like to thank Dr. Rajiv Chudgupi, sir, and ICPA for this wonderful opportunity to share some of my views, some of my experiences on anterior composites in the ICPA clinical series. I think this is a very wonderful initiative started by ICPA. It gives us the opportunity to continue our education sitting in the comfort of our home. And I'm extremely grateful to be a part of this amazing podium. So, my topic for today is going to be unraveling anterior composites. I think anterior composites are a part of our daily work, daily routine for most of us. But somehow, somewhere, something goes wrong and you shy away from using this material to its fullest potential. And what I would like to maybe clarify or help you out in this situation is to provide some simple solutions to some common challenges. Of course, every procedure does come with its own set of complications, and every case that you do isn't going to be perfect. But if you can try and overcome some of the common challenges and increase the longevity of your restorations and thereby make your patients happy, and if it's going to give you some amount of professional satisfaction, I think it's well worth trying it out. So, moving on, today I will be discussing three main aspects which I think are the most commonly used clinical applications of anterior composites. One is decoding diastema closures. Second is invisible proximal restorations. We'll try and see how we can achieve them. And simplifying class 4 restorations. So, what are some of the common problems with composites? There are many. The first slide that you can see right now on your screen are the kind of complications that generally occur maybe immediately after, or maybe after a couple of weeks, months, or years after you've done the restoration. The number one is marginal leakage. These are in no particular order. I have just listed them as they came to mind. Staining and discoloration, secondary caries, fracture or chipping of the restoration, poor contact areas leading to food impaction, and postoperative sensitivity. Some more problems. Now, these are problems which I feel that you face while doing your restorations. And one of the most common one, and I think this is the most commonly asked question, is how to get rid of that white line of demarcation. Shade mismatch, yes, another common problem that we face. Shape mismatch, dull, lackluster, or grayish restorations, and incorrect midline position or a canted midline. You can see in the picture that I have posted here that almost all of these problems are there in this particular restoration. Now, what could be some of the reasons for failures? Yes, the first one I think is an inherent drawback of the material. Composites are not as strong or as stable as far as their color is concerned. nor are they as strong mechanically or physically as ceramics. That is a drawback of the material, but we need to learn how to get around that and still use it in a lot of clinical situations where it will give us good results if we know how to handle the material well, rather than thinking that no, it's not going to work and we go directly onto ceramics. Failure to isolate, a big issue, yes. Etching and bonding protocols, if you don't follow them correctly, you are bound to fail. Improper selection of matrices and wedges. This is very important again, even though it's a very small part of the entire picture. I feel that if you don't select your matrices and wedges properly and use them properly, you could be setting yourself up for a lot of failures. Operator skills, yeah, that is a reason, but I think that's something that you can definitely work on and improve. Curing light, I've put this last, but I really feel that the curing light is something that we all fail to understand the importance of, and that is something that needs your attention. You need to make sure that you're using a good light. You need to make sure that the light is giving you the same amount of output after years of use. There are ways to check that, as I'm sure all of you know. And you need to clean the curing light. These are all very simple things, but they can lead to massive failures of composites if you don't take care of them. So here are some pictures, some clinical situations that I have come across in my practice where patients were unhappy with the composites that they were given. Most of these, as you can see, is some of the causes are secondary caries. There is marginal leakage. This particular one right here, you can see the shade and shape mismatch. Also, not it doesn't have a very good contact point, and of course, marginal deterioration, staining of the margins. This one over here, again, there is a bit of fracture, chipping. It has lost all the luster that I hope that it once had. A dull grayish restoration here on the top left. This case here on the top right is actually one of my old cases. This was before I probably got into the whole artist, the whole aspect of getting things very, very good. And you can see that the contact can definitely be improved. I'm not too happy with the margin, with the transitional line angles or the emergence profile for that matter. This case again on the bottom left, you can see some amount of secondary decay. And the one on the bottom right, I think, is basically a lack of using any sort of a matrix or a wedge, or maybe even isolation, that has led to this kind of a failure. So some of the aspects influencing longevity, patient-related factors, operator-related factors, and the restorative material and technique. When you talk about patient-related factors, you can talk about caries, bruxism or some sort of parafunctional habits, age, socioeconomic status, and aesthetic demand. So our ultimate goal has to be to imitate nature. So we take inspiration from nature when we are trying to replace something that has been lost. Now, if you look at dentine, it is inherently an opaque material, whereas enamel is much more translucent. I'm going to go a little bit into these details because it is important for us to understand the properties of enamel and dentine, and hence the properties of the composites that we are going to select to replace that lost enamel or dentine. If you don't know the inherent properties, then you can't possibly select the right material in the right situation. And that is a very common cause of going wrong with composites. So again, to reinforce that a bit, enamel is an optically translucent material with minor internal hue that modulates the chroma of the underlying dentine. Basically, it modulates the intensity of the underlying dentine. And dentine is an inherently opaque material, but it can let light pass through. And of course, as we know this, the dentine color is continuously changing due to physiologic aging. So you have two types of dentine. You have the primary dentine or the superficial dentine, and you have the secondary dentine or the deep dentine. The primary dentine is less opaque, it has less chroma, whereas the secondary dentine or the deep dentine is more opaque and has more chroma. So this becomes very important for us to understand, because if we are replacing only the superficial dentine, then you can get away with only using the body shade of your composite material. It doesn't matter which brand, all brands have a basic body shade, which is your universal shade, which is going to be the syringe that you go to when you want to replace only the superficial dentine. But if your cavity or your situation is such that you are going to have to recreate some of the deeper dentine, then you have to use the dentine shade, because otherwise what happens is that you end up with a material which has less opacity, and that's going to be seen through as a translucent restoration. So if you see the dentine, it has more chroma towards the center of the tooth, that is towards the pulp, and less chroma as you go away from the center towards the enamel. And it is also more opaque towards the center, and it becomes more translucent as you move away from the center of the tooth. So these are the basic opacities of composite that you will be requiring. You have your dentine shade, which is the more opaque one. You have the body shade, which is the intermediate opacity, and you have the enamel shade. Now, the enamel shade you will use only to replace the lost enamel. The body and the dentine shades you will use to replace the lost dentine. The translucent shade is basically what you are going to use in the space between the mamelons where there is natural enamel translucency. But of course, you use this sparingly, you use this carefully, because a little bit more and it gives a very translucent effect. So use it only if your adjacent natural tooth demands that kind of a translucency. So let's look at some of the basic layering protocols. If you're going to use one shade, I've already explained this. You're going to use your body shade or universal shade. Two shades, you can either use dentine and enamel shade. Three shade layering technique will require the use of the dentine, body, and enamel shade. Whereas multiple shades, that is four or more, you will need your dentine, body, enamel, and your achromatic, that is your translucent, or sometimes even the ones with the blue translucent. So how much enamel you're going to use basically is going to determine how blended your restoration is going to be. And it's very difficult for us to judge how much of enamel you're going to use. All right. So this was a study that was conducted. This is a slide from styleitaliano.com. And what they studied basically and what they concluded was that zero point 0.9 millimeters of enamel completely hides the dentine. So it acts as a unique mask. Zero point 0.7 lowers the value. So the result is too translucent, which means the grayish restoration that you see sometimes is because you have used too much enamel and consequently too less of your dentine shade. Zero point 0.3 modifies it minimally, so you will have a more opaque restoration because your dentine is going to be seen more. And 0.5 is found to be the ideal thickness of your enamel. So whenever you are replacing the enamel, it has to be 0.5 millimeters thick, because this is something that is modifying it without lowering the value. So it is much more close to natural. So how are you going to measure this 0.5 millimeters? This is a wonderful instrument from LM Dental called the Misura. I will explain this in detail when we go to the clinical slides with the photographs. But basically what it does is that if you see the tip, it is calibrated at 0.5 millimeters. And when you place it the way I have shown in these pictures and you drag the dentine shade along with it, what you're essentially doing is you're removing the extra dentine that you have packed, and you are left with exactly 0.5 millimeters of space, which will then be covered with your enamel composite. So I find this instrument extremely useful because it completely takes away the guesswork from your layering. And you can use this not just in a two shade technique, but also in a three shade technique. Basically, all you need to do is that the last layer has to be 0.5 mm thick. So a lot of times we go wrong in shade selection, especially nowadays. You see a lot of cases on Facebook and social media where people are isolating the tooth with rubber dam and then checking the shade. So the first point that I would like to point out here is you have to select the shade prior to isolation of the tooth, because once you have isolated the tooth is going to be dehydrated, and dehydrated teeth will appear lighter than normal. So if you are going to isolate and then check the shade, you are going to be left with a restoration that is lighter than the natural tooth structure. All right, so select it prior to dehydration, so prior to your isolation. What I like to do is I like to first select the shade with a classic Vita shade guide, and then you confirm it by using custom composite buttons. of at least two body shades close to the previously selected standard shade. So if my standard shade is A3, then I will take the body shade of A2 and A3 and put it on the tooth, cure it, and then see what I feel looks better. What you can also do here is you can take a picture, turn it to monochrome mode, and see in the monochrome mode, which is basically your gray, black and white, which is going to look much more normal. All right, so moving on, let's look at decoding diastema closures. So there are many ways to go about diastema closures. Orthodontics is, of course, one of the most preferred methods. But if for some reason orthodontics is not an option for you, then restoratively we can either look at direct composites, indirect ceramics, that is veneers, or a combination of direct and indirect. So there are a lot of techniques that you can use for diastema closures. These are some of them. There's a freehand technique. There's a technique with the palatal index. I used to do the technique with the palatal index, but more and more I've realized that it is extremely difficult to control the composite palatally for a diastema closure. A wonderful technique that I have recently come across and I have been using extensively is this front wing technique that I'll be talking about. It's really made my life with diastema closures much more simpler and much more predictable. You can either do it with sectional matrices, or I've even tried it with a mylar strip and it's worked fairly well for me. You can do an injection molding technique with bioclear matrices, or you can also use the injection technique with the flowable composite resin. So we're going to be talking about the front wing technique and also a bit of the bioclear matrices. So the front wing technique was developed by Dr. Jordi Manotta of the Style Italiano group. And what it basically tells us to do is that suppose you have this situation where you have the space between the midline diastema that you want to close. What you're going to do is you're going to approach the restoration from the buccal aspect. So what this does is that it gives you complete control over how you want to exactly get the cervical contour and how you want to keep the symmetry of the two teeth. A lot of times what happens with diastema closures when you approach them palatally is that you end up with one tooth which is wider and another one which is narrower. And then it's a nightmare to try and get them back to match the same way, because you will have to practically remove the entire restoration and redo it. So I found this technique really useful because it gives me complete control to match that symmetry. So how we're going to go about it is basically, if you have this kind of a situation, the first step is going to be to build the front wings. So you can see the blue portion on the slide. These slides are again courtesy Dr. Jordi Manotta of Style Italiano. You build up one side, all right, and then you build up the other side as well. Once both the sides are built up, you're going to place your matrix. This is the view from the palette, from the incisal aspect of the first layer that has gone in. Next, you're going to put your metal matrix, and from the palatal aspect, you're going to place a very small drop of flowable once you have placed your matrix and wedge. I will show you this with a clinical case so that it also becomes a little simple to understand. And the third step is going to be backfilling the entire palatal segment and curing it. So let's look at a case so that it becomes a little simpler to understand. This is a patient who was unhappy with this diastema. She already had a previous restoration done, which I think had popped out, and she wanted to get it done again. This was the intraoral situation. So you can see there is still some amount of composite remaining from the previous restoration. After, of course, I don't have those slides here, but you will select your shade and then you will do the isolation. Once you have done the isolation, you will etch the tooth, bond it, and now we will start developing the front wings. So you can use a very nice thin instrument like this one over here to develop the cervical contour. And this is what it looks like once I have developed both the front wings. So as you can see, I haven't done anything palatally. It's just the buccal part that I have built up. Next, go in my posterior sectional matrices and the wedge. This picture gives a very clear view of the space that is still there and that needs to be filled up. So you take a small drop of flowable. This is a tip that I would like to highlight here. Use a very thin instrument to put this flowable drop, because if you directly inject it, it becomes a bit of a mess. I'll show you that in some of my next slides. So you put this small drop of flowable palatally, and then you pack in the rest of the composite from the palatal aspect till the material starts flowing out from the buccal aspect. So the entire space gets covered up and you have a nice contact area like this. This is the final post-op, final in occlusion, and her final smile. Another case with the front wing technique. I find such diastema closures extremely challenging because the space is very, very limited. So imagine if you were to do this with a palatal index, there was absolutely no space to put anything on palatally. So the best way to approach this is from the buccal with this kind of a technique. This is the intraoral view. So here is the tip, that you take these composite buttons before you have isolated and you take a picture, and then you see what you feel will merge best with the tooth. What I have done here is simply that I'm preparing the enamel in a way that there will be no bevel. There is no bevel that is needed for composites because you're going to be entirely in enamel, and the bond to enamel is going to be your strongest one there will be. So all you need to do is you need to remove the aprismatic layer. I have done it here with the help of a coarse disc. You can also use some sort of an air polisher or sandblaster for the same purpose. But if you don't have any of this, even a simple coarse disc works fine. All right. So one of the important aspects of trying to get invisible restorations is to etch slightly beyond the area that you think your composite is going to come. If you feel that your composite is going to come about 2 mm, it's always advisable to etch a little bit more and bond that area as well. What happens if you don't etch and bond a little bit beyond is that when you are adapting your composite final layer, there will be some amount of composite. You cannot control where that composite is going. So there will be some amount of material that has gone beyond the area you have etched and bonded. And then when you finish and polish your restoration, you're going to be left with the white line, which is what everybody is so afraid of and they don't want. But it's really a simple solution. All you need to do is slightly etch beyond and bond beyond where you think your composite is going to end, and you'll be in a safe zone. So this is this is one tooth which is built up. You can see very little composite going in. That's the second one. I'm not very worried about how the contact area is looking at this moment because my matrices are going to go in next with the wedge. Yeah, now so this is what I was talking about when I tried this out with the flowable syringe. It was a bit of a mess, so I spent a lot of time taking out that extra material. So it's always better to use that thin tipped instrument that I showed in the previous slides to place this composite. This is the final, and that's the post-op, a final smile. Another case, now for this gentleman, what we have done is that in order to close this diastema, we have used the front wing technique, but instead of using the sectional matrices, I tried to close it with a mylar strip. So this is his pre-op isolation. So if you see all of my cases and the way they follow, they have to go step by step. So you have to follow this protocol to get consistent results. The coarse disc, etching, again a little bit beyond where I expect it to be, the bond, both the front wings developed. So you see how simple it is to actually predict the symmetry of the two teeth when you're doing it from this angle. And then instead of the sectional matrices, I've used a mylar pull-through method to get the contact. That's his final post-operative image and his final smile. Another case, she had these lateral diastemas that she wanted to close. She wasn't happy with the space. Again, this is a very tricky situation, a very small area. You can't really use a palatal matrix here, a palatal index here. This is her left side, and some diastemas in the lower anteriors as well. And this was her post-op once we completed it. Right lateral view, left lateral, and the lowers. This is a case that I have done with a BioClear matrix. As you can see, this was actually a post-ortho relapse case. If you see the contralateral incisor, the shape is a little different from this right one that we need to close. So I had a lot of room to maneuver and to match the shape of the adjacent tooth, the contralateral tooth, sorry. So your composite shade buttons before isolation, isolation. Whenever you're using a sandblaster or an air polisher, you have to protect your adjacent teeth. And this is a very simple way to do it with a metal matrix. So you just kind of loop it around the teeth and you're good to go. This is the BioClear Diastema closure matrix, which has been applied there with the wedge. You etch it, bond it. Now the first step here is to place a small amount of flowable in the cervical region to create a cervical hip. And then you injection mold the rest of it. These are all, this one and the case before, they were all single shade, so single opacity body shade restorations. This is the final after finishing and polishing, and the final post-op. So some of the points to consider for diastema closures are getting good cervical contours, preparing the enamel, because with diastema closures, like I said, you don't really need a bevel, but you do need to prepare the enamel in this way that you need to either use a coarse disc to remove the prismatic layer, or then you can use a sandblaster or an intraoral polisher. You need to get good contact points to avoid food impaction. Symmetry, since it's most of the times you're going to be dealing with midline diastema closures, and symmetry becomes very, very important. Black triangle closure, if you retract your papilla well and you use good proper matrices and a wedge, you will have black triangle closure, and you don't really need to worry about it. The shape and the shade. So let's talk about how we will try to achieve invisible proximal restorations. This was a case with these proximal caries with her central and lateral incisor. This is a young girl. So your shade tabs for shade matching. Isolation with added retraction with floss ties. Cavity cleaning, you remove all of the decay and you place the bevels. Now the bevels for the class 3 and the class 4 composites become extremely important to achieve an invisible restoration, so to say. So the bevel has to be about 2 to 3 millimeters, and it has to be at an angle of 45 degrees. This is the palatal view of the cavity which was cleaned. Etching, bond. That was the central incisor which was completed. At this stage, and for this particular case, I have used a mylar strip to close the contact. Using a good curing light, like I mentioned, is extremely important. Try to use a light which has a large head so that you have more of the surface area which is getting cured. This is the curing pen from 88 Medical, which is an excellent light. This was the final, and that's a post-op. Another similar case with proximal caries. This was a patient who was going to go in for orthodontic treatment. He was a young boy. So there was a bit of a diastema between these two teeth, which I chose not to close, as you'll see towards the end of the slides. So there is, here you can appreciate the bevel much more, I think. I've marked it in red. So you can see that it is at 45 degrees, and also it is about 2 to 3 millimeters. So making this bevel is a very, very important step. Palatally, you don't really need a bevel. This is not required. Etching beyond the margins, bond. This is your, now if you notice that this cavity was fairly deep, so I wouldn't get away with doing just a single opacity restoration, like, or a single shade. So I am going to need to use a dentine shade, maybe a body shade, and then a final enamel shade. So the first layer that is going to go in to replace the deep dentine is going to be your dentine shade. If I don't use this dentine shade and if I directly use a body shade, my restoration is going to appear grayish because it needs that opacity to block the light. That is the body shade completed with the lateral incisor. Some more steps, and that's the final enamel shade. And after finishing and polishing, this is the final aspect of the restoration. Like I said, I've purposely left that gap because he was going to go in for orthodontics and I didn't want to close it. As you can see, this patient has multiple issues. There are some class 5 cavities, cervical cavities, that is, plus a lot of old restorations which are completely failing. So this was after cleaning the cavities properly and placing the bevels. And this was the final for this case. You can see how the contacts, the contours have been restored, making it flossable yet with a tight contact. So this is an interesting case of a diastema closure in combination with a proximal caries restoration. So she came to us with this old filling in the center, and she also asked if we could help her out with the diastema closure also. This was the palatal aspect. As you can see, there is a lot of secondary decay, and the restoration is basically impinging on the papilla. This was after cleaning it, cleaning out both the cavities. And with the same principles and the same protocols, this is where we finished for her. And this is the palatal aspect. So some points to consider when you're talking about proximal restorations is proper removal of the decay. Don't leave any decay behind, so you minimize your chances of having failures later. Isolation, always important. A smooth bevel. So the bevel that you make, it need not be rough. In fact, it has to be as smooth as possible because only then will your composite adapt nicely to it. Using the correct adhesion strategy, most of the times I prefer to use a selective etch when I'm dealing with proximal restorations, where I'm going to etch the enamel and not etch the dentine and then use a universal bonding agent. That works for me, but you are, of course, free to choose what you feel works best for you. Using the appropriate matrix and wedge, correct thickness of different opacities of the composite. Even in this situation, you could use the Misura instrument to check how much enamel shade you want to apply. Curing under glycerin gel, this is an important factor again because you want to cure the last layer, which is an oxygen inhibited layer, so that it avoids getting discolored soon. And proper finishing and polishing protocols. We will talk about this towards the end in the questions and answers. So let's move on to one of the favorite topics for everyone, which is simplifying class 4 restorations. Now, when we are doing class 4 restorations, we are going to be using a palatal matrix technique, a palatal shell technique, all right? And there are different ways to get this palatal shell because all your layering is going to be done on that. So it is imperative that you know the different methods of getting that kind of a shell ready for you. So the different methods to do this is a direct mock-up in the patient's mouth, a wax-up on a cast from the lab, or you can do it by yourself in the clinic, or you can do it freehand with a mylar strip. So if you want to do a direct mock-up, what I mean by a direct mock-up is, suppose like this patient came to me with an old restoration. You can see that it's deficient, it needs improvement. So rather than taking an impression and sending it to the lab, what I did for her was that you can just take any composite that is lying in your inventory, something that you don't use even. You don't need to etch, you don't need to bond, you just adapt it on the tooth, shape it in the way that you want your future restoration to sort of look like, especially palatally, because palatal is what we're trying to record. And you cure it. Once you cure it, you mix your putty, the base and catalyst, and you place it palatally like I've shown in the picture over here, and record the palatal aspect of that particular restoration. Once the material has set, this is what you will have. You will have the entire form of the palate palatal aspect of the tooth, which you will use further for your layering. So this is the direct mock-up. If you don't want to do that and you have some time and you want to plan the case properly, what you can also do is you can send an impression to the laboratory and they do something like this. They do a wax up and they send it to you. Or you could even use again some composite that's lying in your clinic and build it up on the cast yourself and then make the similar putty impression. And suppose you're pressed for time, it's a emergency, it's an emergency case and you need to go ahead and do it immediately, you don't have time to do all of this, you can also try and make it freehand with a mylar strip. This is a little tricky, so if you're a beginner with this kind of restoration and this kind of a technique, I wouldn't really advise you to go for this. But once maybe your hand is more adapted to using the composite and the instruments, then maybe you can try this out. How to do it, I will show in some of the slides ahead. So he was a young boy who, as you can see, has a fractured right central incisor from a fall. He also has an over-retained deciduous canine, and an impacted permanent canine. So he was slated to go in for orthodontic treatment, but obviously before he starts any sort of orthodontics, we need to build this tooth up for him. This was the intraoral view. The composite shade buttons for shade matching. So one more tip that I can give you here is that when you're trying to match the body shade, you can put your composite tabs in the center of the tooth. When you're trying to match the enamel shade, you can put them at the incisor ledge because that is where you will have more of the enamel composite. And the dentine shade, you can place the tabs at the cervical. All right. So this is the bevel that you need for this kind of a restoration. Again, another 2 to 3 millimeter bevel. Initially, if you're new to this, you can even make the bevel slightly longer. Then once you are more proficient and once you're more confident about blending in your restorations well, you can make it a little smaller. This bevel you can make with a red banded burr, okay, and then you smoothen it nicely. You can see it's extremely smooth. That smoothing you can do with your coarse disc. Etching the tooth, you can protect the adjacent teeth with Teflon like I've done here. Application of the adhesive and curing it. Now, this is how I have made the palatal shell for this case. What you do essentially is that you use a nice broad instrument like the Solo Anterior from LM Dental, and you compact the and you adapt the composite against the matrix with your finger for support palatally. This is a little tricky to do. That's why I said that this is a technique that maybe you should not try immediately if you're new to this. But with time, you can definitely try this out. Just adapt the matrix palatally and then start adapting composite. What is very essential to understand here is this is enamel composite you're using for the palatal shell, so it has to be extremely thin. If you make a very thick palatal shell, that translucency of the enamel composite is going to show through and it's going to give you problems later. So you make it extremely thin and you cure it. A nice tip over here is that you can take a small drop of flowable, and as you can see with this very thin instrument, you can place it at the junction of your palatal where the shell comes from and the bevel, and you can cure it over there. So what this does is that since this palatal shell is extremely thin, this will reinforce it and help you with your further layering process. You can remove the mylar strip at this stage, but sometimes I prefer to just leave it in there rather than disturbing it at this point when it's so thin. I would maybe go ahead and do my dentine layering and then remove it. So this is what it looks like once I have placed that very, very small drop of flowable just to seal off that interface. Now, here comes my second opacity that's going in, which is my dentine. I've only used two opacities here, that is the enamel and dentine. So once I have adapted the composite into their entire section that needs to be replaced, I take the Misura instrument, which is, if you remember, the one that I'm going to use to calibrate this, place it on one side or at one end of the tooth and drag it towards the other end. So from the mesial, I drag it towards the distal, and whatever extra composite I have already placed, that gets pulled off. You can see towards the end of the instrument that extra blob of composite. That is all that was extra, which will come out. So what I will be left with is essentially 0.5 millimeters of space, which I will fill up with my enamel composite. This was once I have removed out all of the excess dentine shade. Now the next stage for me with my dentine layering will be to adapt this composite well. The dentine layer will always be thicker towards the bevel, and it will thin down as you approach the incisal edge. So your nice way to do that is with the brush. Then you give the dentine anatomy that you want with the mamelons. A lot of people prefer to do the mesial and distal proximal walls before they do the dentine stage, but somehow I like to do it this way. So that is my enamel shade going in for my proximal walls, mesial and distal. And this is what I am left with after the entire layering is over, except for the final enamel shade. This is the final enamel layer going in. To model the last layer of composite, again, you can use this broad instrument, or if you don't have this, even a brush is fine. Now, at this stage itself, I like to get most of my anatomy and the line angles right, so that there is minimal time and effort spent in finishing and polishing. So if you have a lot of extra material, then you spend a lot of time trying to get that out. So try and be as, you know, make sure that it is not too much of excess. Minimal. That's the final after the layering. And this was immediate post-operative. What I like to do sometimes is that at this stage, once I have finished off majority of my finishing and polishing, I send the patient back and see him again and on another sitting for the final polishing. This was the final polishing with the Lucida polishing system, and that's his final situation. That's a smile. Another young girl with a fractured right central incisor. She actually had come to us maybe 6 years back with those fractured fragments in hand. And since she had come to us immediately, we had reattached them for her. But about maybe a couple of months back, one of those fragments came off. And we decided that now was a good time to go in for a direct composite restoration. So the fragment on the left is actually still intact. You can see that little bit of a difference. You can see that line with the transitional line which is seen over there. So this was the situation that she came to us in. Her father actually wasn't very convinced about replacing the left tooth also, but she was insisting on it. But we said, okay, let's do the right first and then let's see where we are. So we isolate, clean everything, give a nice smooth bevel. This was the palatal index. You verify it before you etch and bond so that it fits properly, because sometimes the clamps interfere and you don't want to make those adjustments later. Etching, bond. This is the enamel composite going in. That's her palatal wall. That's the dentine shade with the mamelons. Now here, since I want to get a good contact, I have used these sectional matrices. And that's the mesial wall being built up. And that's the final layer. So this was after basic finishing and polishing for her right in central incisor. When she came to us for the final polishing, she said that no, I want to replace the left one as well, because she wasn't happy with the way it looked now. So in goes our rubber dam again. We remove out most of that fractured fragment. Putty index, etching, bond. That's the palatal shell. Sometimes when you are making this palatal shell, if it's a little longer than the adjacent tooth, you should probably just reduce it a little bit at this stage rather than finishing your entire layering and then reducing the length. That's something that you can do. That's the dentine shade and the enamel shade for the proximal walls. And the final. This is the curing under glycerin. And that's her post-op situation, perfectly integrated restorations. And she was extremely happy with that. Another young boy with a similar fractured tooth. That was his pre-op. Now, like I said, since he was a very young kid, he was already quite fed up with sitting in the chair for quite a while I was doing the restoration for him. So I sent him home at this stage with just one or two pictures that I took to evaluate how everything's looking. And what I noticed was that the line angles, the transitional line angles mesially, are not really matching each other, which is why the tooth looks a little broader and you can see the obvious asymmetry, even the length. So, to get perfectly matching restorations, this is something very important, is to get these transitional line angles right. Because once I do them, you can notice the immediate change and the immediate difference in how my restoration looks. And that was his final, and that's how he goes home. All right, so this is another case of fractured tooth. We had actually done this case back in 2018, so that was about 4 years ago. But the patient went and bit on a sugarcane, the entire stick, and obviously my poor restoration couldn't really take that, and it chipped off again. So he came to us a couple of days back requesting us to do it again. So even though I had done the restoration before and it did come off after 4 years, I'm still convinced that I can do it again and it is going to last. Probably the only thing I tell them to avoid going forth is biting into a hard sugar cane. So the bevel was already there, so all I have to do is just clean it a little bit, polish it, new etch it, bond. This was freehand palatal shell. That's the mesial wall. All right, so here again, this is how you're going to use the Misura instrument to calibrate the dentine shade. That's the final enamel shade going in. And this is his immediate post-op. Now, if you look carefully, there is a bit of translucency that you can see in the restoration. That is something else also that you need to remember is that since you've isolated the tooth for so long, the teeth are dehydrated. So do not get worried and make any changes immediately to the restoration at this stage. Wait for 48 hours minimum and then make a call whether you need to redo the restoration or make some sort of changes. This is how he came to me after 5 or 6 days with a completely hydrated tooth. And I find that I don't really need to do anything. It has merged and it's completely invisible now. That's his final smile. So some points to consider: shade selection, isolation, enamel prep. So it's the same thing again for almost all the situations. Smooth bevel at 45 degrees, edge beyond bevel, putty index, appropriate matrix and wedge, understanding the effects, if present, in adjacent natural teeth, including the dentine anatomy. So if your adjacent tooth has the anatomy that you want, like the mamelons, only then you're going to sit and create them. Suppose it is a tooth which is a little abraded and it has a flattish dentine anatomy, then you don't need to sit and make the mamelons and such. Layering protocol to be followed, that is something that you need to decide beforehand before you start the case. The correct thickness of different opacities of composite, I think this becomes a very key factor when you're trying to make invisible restorations, is how thick which each layer is. Curing under glycerin gel and finishing and polishing protocols. So this is towards the end of my presentation now. Some tips that I would suggest is you must follow protocols. Keep learning. There is no end to learning. And the most important one is practice, practice, practice. Nothing comes without practice. You have to put your heart and soul into trying out different things. And the most important thing is not to be disheartened when you get a failure, because that is your biggest learning. That's the only way that you'll really learn from your own mistakes, and of course mistakes done by others, but especially more than that, your own mistakes, because then you know that you're never going to repeat that again, and the predictability of your own work increases. Also, start documenting if you aren't doing it already, and start sharing whatever you are doing, because there are a lot of things that may miss your eye, but maybe to a colleague or a mentor, if you share those pictures, they will be able to point out things that you don't see. And that is the way you keep improving yourself until you feel that you are now doing your best. That's all I would like to say on that. So this is a very nice thing that Benjamin Franklin once said: "Tell me and I forget, teach me and I remember, involve me and I learn." And the last line I heard at one of the lectures at our ESCD conference by Dr. Professor Rad Paravina, who is the inventor of the 3D Master Shade Guide, the Beta Shade Guide. And he put in the line saying, "Inspire me and I excel." And that is something that has really stuck to me, because I have been inspired by so many wonderful mentors from all over the world, and I would not be here was it not for them and their guidance at every stage. So I would really like to thank them from the bottom of my heart. And thank you so much for patient listening, and thank you, ICPA, once again.
Thank you, Nisha. It was a fantastic lecture. You made it very relevant and you simplified a lot of things and gave away a lot of clinical tips. And there are some questions from the live audience, but before I take them up, I would like
Sure.
to take the questions which have been sent by our audience who had registered for this event prior,
Yes,
much
sir.
before. Okay, so the first question is, what precautions do you take to minimize fracture of restorations, composite restorations?
Right. So to minimize the fracture, first of all, you need to follow all the adhesion protocols. You have to etch the enamel. You have to use the rubber dam for isolation. These are some of the protocols that you need to follow regardless, which will definitely increase the chances of survival of the restoration. And also, something very important that sometimes we fail to neglect is checking the restorations in eccentric occlusions, especially your protrusives when you're dealing with class 4 buildups. So I think that really helps, and following all the protocols.
Okay, and there are many questions on what things you follow in your finishing and polishing protocol. This has come in the registered people's queries as well as in the live audience. So
Yes.
this, I
Okay.
think, is the most common question. How
Yes.
can I finish and polish contacts in anterior composite restorations? Is it
Okay.
necessary to use polishing strips? And what finishing and polishing protocols you follow yourself?
Okay. So for the proximal regions, you do need to use the finishing and polishing strips, because there is no other way that you can reach that area. One way to minimize the need for finishing and polishing proximally is, like I said, to use the proper matrices and wedges, especially when you're using the mylar strip and you use the mylar pull through. You usually end up with a surface which is already very smooth, so you minimize the need for using finishing and polishing proximally. But yes, that doesn't mean that you can get away with not using strips. You still need to definitely use your proximal strips for finishing. The protocols that I follow are something that I have devised over a couple of years of trial and error, and it has seemed to work for me well. I will give you a general idea of the workflow that I follow for finishing and polishing, and you can modify it as in how whatever suits you. So the first step in finishing and polishing basically is to get rid of all the excess composite that you have, and at the same time try and give the tooth the shape that you want. So while you are removing the excess composite, you need to first mark the transitional line angles which you want, that should be more defined and which have to match the adjacent tooth. And once you mark that line, especially the transitional line angles, you don't touch those lines at all in your finishing and polishing procedures, because the minute you move your burr or you move your disc over them, you lose whatever you have built and you end up with flattish restorations. So mark the lines, do not touch them. If you feel that the pencil mark is going off at some point, you can remark it so that you keep visualizing where you want your transitional line angles to be. So the first step is to remove out all your excess composite and give the tooth the basic shape that you want. You can do this with your coarse disc, or you can also use some sort of a burr like a diamond point, which is red banded, preferably one which is tapered, or you can even use the carbide fluted burrs. All right. So use any one of these. I prefer to use the red banded diamond burrs and the coarse disc in conjunction. Some areas like the incisal edge, I will prefer to use a disc because I have more control. But certain areas where I want a lot of excess from the buckle removed, I can use the red banded burr. Palatally, you can also use a red banded football shaped burr. These are all simple burrs which are found. I mean, you can get them easily with your dealers. And once you have done that, and once you feel that all the excess composite is out, you have two options. Either you move on to the rest of the grits of the polishing discs, or you can even move on to the rubber polishers. Now in rubber polishers you have the Soflex spirals. All right, either you use those, or you have a lot of these other spirals that you get, like the Shape Guard from Colteen, or the ASAP polishers, or the Eve twists. Any of these work perfectly fine. You can choose whatever works best for you. And they have two grits. You use both of them. The first one does a bit of pre-polishing, and the second one does a bit of it gives a better gloss, and you are pretty much done with the entire thing. All that remains is your final polishing, which you will do with a paste and either a felt or a buff. The polishing paste can be either an aluminum oxide one or a diamond polishing paste. And what you can use with that is something like a cotton buff, or you can use a goat wheels brush, any of those. So, what is more important than what you use is how you use them, and the sequence in which you use them. So, I hope that helps with the finishing and polishing.
Yeah, I think you detailed it very well. And next, I think there are many questions on instruments. I'll just read out three related
Okay.
questions.
Okay.
Uh, the registered audience had asked, they had sent a query: which are the must-have instruments for composite restorations? And from the live audience, one person has asked, name the instrument which you used in the restoration. I don't know which one he's mentioning. And also, can you name the
Okay.
two instruments again, the broad one and the calibration one?
Yes, the instrument which I use for calibration is the Misura, MISURA, which is from the LM Dental set of instruments, the LMRT set. The LMRT set are basically specialized instruments for composite restorations. They are a set of basic instruments is a set of five, and then they have some more extra instruments that you can have in a set of eight, and they've also added in extra instruments after that. The broad instrument is an instrument called as a solo anterior, again from LM Dental itself. And that is the instrument that I like to use as the final layer, or to make the palatal shell if I'm doing it freehand. So these are instruments that I have been using now since many years, and I think they are one of the best in the world. But honestly, it's not the instrument that really matters. I can even do the same restoration with a simple composite instrument like the plastic filling instrument that you have. What you also can do is maybe not invest immediately into these, but if you're just beginning, then you can just buy the simple set of instruments from GDC, or there are many brands which have them. But invest in a good composite brush, because a lot of the adapting, a lot of the sculpting, the final layer, the final shaping that you do with the brush. So I think the brushes are really important when it comes to anterior composites.
Okay, that I think solo art. What was that
Solo
instrument you had?
anterior. Solo
So that's the
anterior.
same thing, right? You had reviewed in Dental Tribune.
Yes, yes, yes.
Yeah.
We
So
have done a review for that.
I would like to tell the audience that Dr. Nisha Deshpande is also the assistant editor of aesthetic dentistry in Dental Tribune South Asia. She not only interviews the stalwarts in aesthetic dentistry, but she also reviews some of the latest instruments. So I invite all of you to visit Dental Tribune South Asia website and read her articles. And she has reviewed all these instruments, how to use them. She has really made the whole configuration and the specifications very simple for clinical practice. All right. Now there are two questions about how to use some chemicals. I don't know. Somebody has asked, can we use clinical spirit for polishing? And somebody has asked
No.
how to use glycerin gel.
Glycerin gel is only to be used after you have finished your entire restoration. What it does is basically that it allows you to cure the top layer of composite. so that the top layer, which has the oxygen inhibited layer, gets completely cured. If you don't use that, then you are left with a top layer which is slightly uncured, and that is going to attract a lot of stains, a lot of bacteria. And sometimes when you see your patients immediately after and you see the restoration has become completely yellow, that is what has happened, is that the oxygen inhibited layer has come to the fore, and it has made the restoration completely discolored. So to cure that last layer, you just have to apply a layer of glycerine gel and cure it through that. That's it. And then wash it off. Nothing else to be done.
Okay. Last few questions. Sometimes a white line appears between tooth structure and the restoration. How to prevent this, and if it appears, how to manage it?
Correct. So that is exactly the first point that we spoke about, is that you will first of all bevel the tooth properly. And once you have beveled it, when you're etching and bonding it, you will slightly etch and bond beyond that bevel, so that even when you're adapting your composite in the final layer, even if it does move on to the areas where you were not expecting it to go in, it will still be on areas that are etched and bonded. If you etch beyond, if you don't etch, if you only etch just the limited portion of the bevel, then the composite goes and ends somewhere else where there has been no etching and bonding. And once you do your finishing and polishing, you get a nice white line which is going to demarcate that restoration. So you have to always etch and bond beyond and have a good bevel which has a very smooth edge.
Okay. Is there
That
any
will help.
particular brand you suggest for glycerin gel?
No, nothing, anything over the counter that you get in the local pharmacy. Just you just go
Okay.
and ask them for the lubricating gel. That's it.
Okay.
No particular brand.
Is in class 4 whether a bevel is required on the palatal side for the palatal layer?
Not needed. Not needed. I never bevel the palatal side. It's not needed at all.
Okay.
You can
Okay.
have a but you don't want to leave that margin sharp. You still want to round it off so that you have a round interface. You don't want any sharp edges, but you don't need to necessarily bevel the palatal.
Okay. How to achieve seamless restoration margins in composite restorations? Have you
I
covered
think
this?
that's the same thing. It's the
Yeah,
same
yeah,
thing.
yeah.
Seamless. Yeah.
What is that one all important tip if you want to give them to prevent discoloration of composites in the long run?
Check your curing light. If you're not
Great.
curing it well, then you are going to end up with a problem no matter what you do. So make sure that your curing light is doing its job, and finish and polish your restorations well. If you spend a good amount of time finishing and polishing, sometimes takes me up to half an hour or 1 hour just for one tooth. So you really have to spend a lot of time, sometimes maybe even redoing parts of the restoration just to get it right. But it's well worth the effort when you see your cases after 3 or 4 years or 5 years and it has retained that amount of polish. So finishing and polishing and checking your curing light, I think, is really important.
Okay. Is there an economic alternative to intraoral sandblaster or air polisher for the removal of plaque and smear layer later after bonding?
After bonding.
Before bonding, sorry.
Before bonding. Yeah,
Yeah,
so that's why I said I think I already covered that in the lecture, that if you don't
yeah,
have the intraoral polisher, you can use a coarse disc. When I didn't have one myself, I have always used just the coarse disc, and it works well.
yeah. Okay. Now the last question, it's a very long question. Okay, I will be reading it out completely.
Okay.
I wish to upgrade my composite work soon, but there is so much variety to choose from, for which I require a universal one that works for 80% of my cases, and custom shades, a white shade, 2, 3 dental shades, enamel and transparent for isolated aesthetic results, which I use less often. In the past, I had to throw away many composite materials which I had purchased, and there was a lot of inventory loss. Is there a system which minimizes this inventory loss without compromising the basics, such as handling the material, polishability, working time, etc.? Some systems have too much variety but short expiry, which adds to the hidden cost and inventory loss later.
Okay. All right. So, what I would suggest to someone who wants to upgrade their inventory is that, and you don't want to spend too much on it initially, is that you invest in the A group of shades. So you buy your typical A1, A2, A3, maybe A3.5, because 80% of the cases that you're going to use shades from the A group of A range of colors. So instead of buying the B and the C, maybe those you can buy on a case to case basis. When you have a case which needs that kind of a color, you can go in and buy that. To just stock up on your inventory, I think these specific shades work well. Out of that, probably the A2 and the A3, you can go in for the entire range, that is the enamel and the dentine shade as well. Maybe the A1 and the A3.5, you don't really need to purchase that initially if you don't want to. But you do need to have the dentine shades and the enamel shades if you want to do aesthetic restorations, because, like I said, just using a body shade in every situation may not be possible. If you have to replace the deeper dentine, then you are going to need the dentine shade as well. So there is no option there. If you want to do restorations that are invisible, you have to use the correct opacities. As far as simplifying the process goes, there are some systems which have lesser amount of complicated shade guides, like a system that probably will be introduced in India soon, which is the White Dental Beauty Professional Composite System, which has only dentine shades and it has just one enamel shade, which is supposed to blend in perfectly with all the dentine shades that they've given. So I feel that that has significantly reduced the inventory as far as shades are concerned. But that is a system which is still to come in here. Let's wait and watch how that goes. But other than that, with the current systems that we have, you do need to invest in the enamel, dentine, and the body shade if you want to do proper aesthetic restorations. And what I would suggest is that if you're buying it, make sure that the dealer gives you something that has a long expiry to begin with. Don't buy something that's going to expire in a year or so, so that you have more time to use all the materials that you have.
Okay, one last,
That's it.
absolutely last question. What is your
Yep.
opinion about contour matrix band? Is that to be used?
Contoured
Contour,
matrix band.
yeah.
Okay, maybe they are talking about the ones like Garrison. I haven't honestly used them. I have, if you're talking about the pre-contoured ones for the sectional matrices, then you can see in all my presentations I use those quite a few. But if you're talking specifically about the Garrison bands which have come in for the proximal restorations, then honestly I haven't used those yet, so I can't really give an opinion on them. But the pre-contour sectional matrices, which generally you use for your posterior restorations, work very well in anteriors, like I have shown in all of my cases almost. So yes, those are definitely over the buy.
All right. So that brings us to the end of this session. That was a great session, Nisha. Great lecture,
Thank you
and
so
you have
much,
answered
sir.
all
Thank
the
you.
questions. You really took time and detailed everything. And I'm sure the audience have got a lot of tips to take home and immediately apply in their practice. And that ends our episode 14. And soon we'll be coming up with our next episode. The announcement will come soon on social media about episode 15. So once again, I would like to thank our today's speaker, Dr. Nisha Damle Deshpande, for coming in and taking this exhaustive session. Thank you,
Thank you
audience,
so
for
much, sir.
joining
Thank you
in,
for the opportunity.
for making this session successful. So good night and take care.
Good night.